introduce myself. I'm Bobby Watts. I am the CEO of the National Healthcare for the Homeless Council. And I first came to my first CCHF conference 3 years ago when Steve Noblett said, I want you to come and make a shameless plug advertisement for the council. So this is my third year. And I'm still going to make a shameless plug for the council advertisement, letting you know what we do, because I just know it is so helpful for those who are serving people experiencing homelessness. And really for these same principles go forward to serving any vulnerable population. So a little bit about my background. I've been in this role for 8 years, and I'll tell you later basically what the council does. But prior to that, my first experience with homelessness was when I deferred going to graduate school for public health for a year to work as a living counselor at a rescue mission in New York City, which is where I grew up and where I've worked all my life until moving to Nashville 8 years ago for this role. And that year, living at the rescue mission was really changed the course of my career. Ended up working there for 2 years and learned a lot about homelessness. And anytime I had an opportunity to do a paper while I was in graduate school for public health, it would be around healthcare for the homeless. Part of my job when I was living there was to be a liaison between a clinic that would come on staff site twice a week. If I saw someone who was like, Frank, I don't want you to go out today. I want you to stay here when the doctor comes at 1:00 for them to look at that wound on your leg or listen to your chest or whatever. And I just saw how important healthcare was to our ministry. We weren't health professionals, didn't have any other access, and just saw how important that was, and ended up after graduate school working there. Long story short, for over 20 years, the last 12 as the executive director. Started as an intern, we're very small, and then succeeded my mentor and the founder of our agency. So let me just ask you, how many of you are serving people experiencing homelessness now? Okay, great. And let me ask, how many of you, if you know what this means, are a Healthcare for the Homeless program under the Federally Qualified Health Center Act? Okay, none. So you're serving people experiencing homelessness. How many people say that they're not currently serving people experiencing homelessness in your clinics? Okay, one or two. All right. Okay, so let me ask you, how are you defining homelessness? Anyone? You're serving homeless people. What does that mean? Okay. Does it have consistent residence? Doesn't have consistent shelter? Thank you. Anyone else? Does everyone agree with that definition as to how you're looking at it? So where might they be living? They could be squatting, living in an abandoned building, in a hotel, so temporarily staying in a hotel, in a shelter, cars, on the streets, friend's house, couch surfing, doubled up. Yeah, good. Yep. So the reason I ask is because defining homelessness is not necessarily intuitive or simple. The federal government has at least 3 definitions of homelessness. They're formed by different statutes. So HUD has one definition, Health and Human Services, which is over healthcare, has another definition, and the Department of Education has another definition, which is the most generous. So how you define homelessness makes a big difference when we answer the question of how many people experience homelessness at a given point in time, or how many people experience homelessness in the course of a year. So just for this point, we'll just be using, except I'll make one reference to the Department of Education, some of their statistics. But what it really means is we recognize the instability, as has been said, of someone's living arrangements. That's critical to the definition. So Health and Human Services definition is more generous than the Housing and Urban Development, which really looks at length someone is in an unstable, versus for Health and Human Services, which is over Health and Humans, Health Resources and Services Administration, which is over the Bureau of Primary Health Care, which is the federally qualified health centers and others lookalikes. They use a much more generous definition. So mentioned shelter, transitional housing, permanent supportive housing, doubled up, street, other, and sometimes when we ask people, we just we don't get an answer. And that's a good question. How do you know the person is experiencing homelessness when you when you answer that question. How do you know that? A lot of times you don't. Okay. And for those who do know, how do you know? Social determinants of health screening. So you're asking them. Okay. Someone said something else? By their appearance, by their clothes. Disclosure. I'm sorry. Big difference. Disclosure. They reveal it to you. So when I was living at the rescue mission, everyone that was seen by the clinic that came to visit us, they knew that this person was unhoused. The main thing is often we can't know unless we ask, and many people will not reveal it, sometimes even when you ask them. So how you ask is really important. So I learned pretty early on, if you ask someone, are you homeless? They may say no. So it helps to probe. And so we would ask the question when the health center where I work, part of our intake was, where did you sleep last night? And that could be revealing because they may say, well, I stayed. If you ask them, are you homeless? They may say no. Say, where did you sleep last night? They may say, well, I'm staying with my friend. Well, how long have you been staying? Is your name on the lease? If they told you that you had to leave tomorrow, would you have another place to go? Could you stay there? If they didn't want you to stay, how long could you stay there? So asking some of these questions helps us to really understand what someone's living arrangement is and whether they are really experiencing homelessness or not. So have a bunch of slides, but the main thing to take out, how many people know what the PIT count is? Tell those who didn't raise their hand. What is the PIT count? Right. Thank you. Point in time count. So, one night in the year, and this is organized by HUD, the Housing and Urban Development part of the government, where they have arranged for, usually as volunteers, but it's controlled and organized by a city or a county that receives HUD funding to serve people experiencing homelessness. Usually it's in January, and they send people out. Counting the number of people in shelters is relatively easy, but then they also go out on the street and try to find people who are experiencing homelessness, document how many, ask them questions if it seems appropriate, to get a rough idea of their age, to understand how long they've been out on the street. And they ask these questions for those in shelters and those on the street. Part of my background is epidemiology, so I love data. And this count gets criticized a lot because you would do it for many, many years, volunteer in New York, and now I live in Nashville, and they have different methodologies. So, for instance, in New York City, they say don't go into the parks, and in Nashville, you do. One of the things, almost everyone agrees that this count is an undercount, and it's not really a count. It really is an estimate because they use a mathematical formulation to come out with a fuller, more accurate estimate. But it really is an underestimate. Almost everyone agrees. The benefit is that it has some things that people are using across the country, though there is some variation, and it's the same count. So you can look at trends over time. Even if it's not completely accurate, you can see trends. So the long-term trend, this is the count, and you can see the top one is all people. The middle one is those who are in shelters, and the bottom one is those who are unsheltered, homelessness. So you see it was a slow decline from 2007 until about 2017, 18, and then it started increasing slowly. And then after COVID, there's a break where we didn't really count those on the streets. So there's a break there. And then after COVID, it went up drastically. These next slides show just some of the data and some of the trends. This one is for the 2024 count, where it's by age group. And one thing to look at from the under 18 and 18 to 24, the bar in the middle is those who are experiencing sheltered homelessness. It's a lot more than those who are unsheltered. Among adults, 25 to 34, it's about even. And then after that, for every age group, there's, as you get older, you'll find more people who are unsheltered than sheltered. So and that has been fairly consistent over time. So this is, most people think of people experiencing homelessness, they think of a single adult on the street. But the fact is that, again, most people who are experiencing homelessness, about 64% are in shelters, at least in 2024, the count, versus 36 on the street. And about this one, let me go back. This one. This is families, the estimate of families with children, and they make up roughly a third of people experiencing homelessness. So we often forget about families and children. Most of them, fortunately, are in shelters. You can see the top line is the total, the middle line is those in shelters, and the bottom line is those who are unsheltered. Fortunately, most families with children are in shelters. Relatively fewer are on the streets, but one is one too many. That is no place for a child to grow up. And on the streets includes in automobiles and so forth. And again, all of these are estimates because it relies on counts on one night and also to some degree, people self-reporting. Let me pause and just shift a little bit. The one bright spot, there are several bright spots, but the biggest one we see coming from the PIT count is that the number of veterans experiencing homelessness has been going down consistently. And in between 2023 and 2024, this is the only group that saw declines. The other subgroups saw increases. And actually from between 2009 to 2024, the number of veterans experiencing homelessness has gone down by 55%, much more than half. It's about half. Anyone want to say why they think that may be? Any guesses? Anyone know? They have pretty assertive social workers that go and find the veterans. Anyone else? I saw other hands. Anyone else want to add to that? The question is, are the Vietnam veterans passing away? That could be. Yes, that probably is it. People will look at mortality, the effect of this on experiencing homelessness on health. That could be it. So, gonna go a little further. Let me just look at. Let me skip ahead. So here's the story with homeless veterans, and this is one of the success stories. So there were in the 2024 PIT count, there were about 33,000. That's down from over 35,000 the year before, an 8% drop. So a drop of just under 3,000 people experiencing homelessness. And there were fewer unsheltered homelessness. Again, this time it's about a third of those who experienced homelessness were unsheltered. And that was an even bigger drop. And here is a really important understanding of why we have so many people experiencing homelessness and what we can do about it. So according to the HUD and the Veterans Administration, they placed more than 90,000 homeless veterans in 2023. So when they did the count in January of 2024, there were fewer. And of those, some went into transitional housing, but 48,000 were permanently housed. So now I said the number on the PIT count dropped by about 3,000, but they said they housed over 90,000. So that means there were 87,000 new people, veterans, coming into homelessness. Either they had been placed in housing before and they lost their housing, or they're becoming newly homeless for the first time. And so this HUD VASH stands for HUD, Health and Urban Housing and Urban Development, and also the Veterans Administration. They have a special program with supportive housing, and it's called HUD VASH. Who knows what supportive housing is? Yes.
Housing where they have around
Yeah. Where there is built-in case management, supportive services built into the housing. So this is a big advance. I've been doing this work for over 35 years. And there's so many things we've learned from when I started at the rescue mission. And supportive housing is really an evidence-based best practice. And it is usually called permanent supportive housing. So when they said they were permanently housed, it usually is for people with chronic conditions, mental illness, substance use, increasingly physical disabilities. So people who will need supports for life, and they build it into the housing. So they're not just leaving them, putting them in an apartment and leaving them to fend for themselves. They build it in. And this has been hugely successful. And really, the number is something like over 90% of people who move into permanent supportive housing stay there for years and years. So almost Certainly, this increase of 90,000, most of that is not people falling out of housing if they were in permanent supportive housing moving forward. So here we have what some call the silver bullet. We have special housing vouchers. The supportive housing voucher is a special voucher so that they can that pays their rent. So they only pay a certain percent of their rent. Usually it's 30% of their income. Many of them have disability payments, which are low. So they have permanent housing support in the form of making housing affordable for them, plus the services. So this can work for every subpopulation. But the fact is, as a country, we have made public policy choices where we drastically underfund that. And that has not always been the case. When I was growing up, I grew up in a poor neighborhood in Brooklyn. There was poverty, but there wasn't mass homelessness like we have now. And the fact is, the 1979 was the last time there was enough Section 8 vouchers making housing affordable for poor people for every household that qualified. Now, we only have enough funding for 1 out of every 4 households that qualify. And so the differences between 1979 and 1982, over that period of time, Congress cut the support for HUD to make housing affordable from $77 billion in 1979 to $17 billion in 1982 dollars. And it has never increased back up to that level again. Right now, in 2025 dollars, HUD's budget is about $50 billion. And if it were just to keep up with inflation, not talking about how housing is much more expensive and our population has grown, it should be $125 billion. So as a nation for 40 years, with very few exceptions during the housing stimulus from 2008 and 2009, and then with the COVID funding, which has now gone away, we have been systematically underfunding making housing affordable for poor people by the tune of $75 billion in today's dollars year after year after year. And that is really a big reason why homelessness began to explode in the early 1980s. There are other reasons, but in my opinion, that's like 80% of the reason. So one of the difficulties and one of the weaknesses of the point in time count is just 1 point in time. So some other numbers to say what is the magnitude of people experiencing homelessness is looking at some few things. So over the course of a year, according to federal data, over 1.5 million people use shelter, distinct individuals. There may be some slight undercounting if someone was counted in one city and they moved to another city and use a shelter, or one state or another. But generally, this is 1.5 million people used a shelter in the course of a year. And this is actually the 2023 school year, 1.2 million school children ages under 18 experienced homelessness. And that's 1 out of 41, or 2.4% of school-age children are counted as experiencing homelessness. And this is almost definitely an undercount. My wife is a school social worker, and she worked with people experiencing homelessness before I did, and she was the point person. Every school district is supposed to have a liaison to all the schools to let them know of special funding available for their homeless families, extra resources. The school district is to give them a choice, I think is within 50 miles, of letting them stay at their old school if they're in a shelter and they're moved, to give them a choice of making sure they get back to their old school in the middle of the school year so there's not that disruption, or helping them get to another school with supports. There's lots of supports. And many of the families do not want to report that they are experiencing homelessness. I had a great conversation with someone in my organization. She was Native American, and I believe in Minnesota, I'm not sure. And she was living out of her car. And she said, I will not let them know. I did not let the school know that we were experiencing homelessness. I made sure they were dressed clean, washed, because I was afraid that they would take my kids away. So many, many people, though there are resources, don't report it. So this is definitely and almost definitely an undercount. So what is the connection between homelessness and health? This is the Christian Community Health Fellowship Conference. Many of us work in health. What is the impacts of health on people experiencing homelessness? Yes, right. You mentioned many of the causes, so I'm just going to lack of access to adequate food and nutrition. The first thing you saw, this was basic. Environmental exposure to the elements, to cold, to heat, now increasingly becoming a problem. Also, exposure to violence. I was asked by a group of newspaper editors to speak to them, and they said, when we're covering people experiencing homelessness, what lens should we put on? And one of the things I said was, you know, unless you're reporting a crime, unless the person experiencing homelessness was the victim and it was related to them being homelessness, or if they're committed the crime and it's related to them being experiencing homelessness, don't report their homeless status. We don't report if someone is arrested, whether they lived in an apartment or multi-dwelling house or what, we don't report that. So if it's not related, don't report it, because it perpetuates the stereotype that people experiencing homelessness are disproportionately violent. And there could be some of that, but by and large, people experiencing homelessness are much more likely to be a victim of being of violence than being a perpetrator. So all kinds of environmental exposure, lack of ability to store medication and supplies. Even if you have needles on the street to take your insulin, that can become a target for others. That could be a target for the police. Why do you have this drug paraphernalia? So it's hard to store. If they needed medication, can't do it. Lack of access to culturally appropriate care. My first exposure was at the rescue mission, and one of the best things that happened early on, a group of the guys living there, like for my first week, they said, come spend a couple of days with us on the street and see what it's like. And I'm so glad I did. They kind of took me under their wing. I saw where they went to get food. I saw where they had to try to lie down. So I'm getting rousted by the police. I saw how they were treated. And also going in, and when I was in graduate school for public health, right across the street from the medical center was a large men's shelter, the largest men's shelter in New York City. I would go there, talk to the guys during lunch and talk with them. And I found out many of them were just mistreated when they would go into the emergency room. The phrase was, they would say, I have 2 female and 5 male Gomers. Whose turn is it? Gomer is short for get out of my emergency room. They would just, treated them as the problem instead of someone who has a problem. And often they would just give the person a token to say, take this and go down to Bellevue Hospital or Harlem Hospital, the public hospitals. And this was a world-class academic medical center. So I would start an organization, and we accompanied them to the emergency room to try to get them care, health education in the shelter, but lack of access to culturally appropriate care. When people are rejected, they will reject that feeling. So when we say only human services, say someone is a client is service resistant. No, our services are resistant to them. No other industry, no other person does that. No other group does that. If I buy a Toyota instead of a Ford, the people at Ford say, oh, they're just so stupid. They don't know what's good for them. They're just Ford resistant. No, they say, why did they choose this instead of that? But in healthcare and human services, we don't. Lack of transportation was mentioned. Lack of a consistent place to sleep. There is an epidemic of insomnia among people experiencing homelessness, from the elements to the noise to being rousted by police. And lack of sleep does all kinds of things to our bodies. Makes it hard to control your blood pressure, your blood sugar, your mood. Think of how we are when we wake up without a good night's sleep. We're slower, we're quicker to express temper, and imagine if that is consistent. And according to the Geneva Convention, consistent sleep deprivation is a form of torture. So this is what our neighbors are experiencing through conditions, I would argue, that we as a society allow to happen, and vulnerability to violence. So the impact of that is that for every condition, people experiencing homelessness experience them at elevated rates, every condition. And experiencing homelessness makes it harder to receive treatment. The health problems cause homelessness, and also homelessness causes health problems. Many people fall into homelessness because of health problems. They've lost their job. They can't work enough hours. They can't work overtime because of health problems. The number one cause almost every year for the last 4 decades, with a few exceptions like the financial crisis, the mortgage crisis, for a very short period of time. Medical bills is the number one cause of personal bankruptcy. So people with poor health are more likely to lose their housing and fall into homelessness. The most serious effect of this is that people experiencing homelessness die prematurely, and for every age group, much higher rate of dying within that age group than the general population. For every age group, overall, 3.5 to 4.2 times more likely. This is from a fact sheet that we put together last year. This says 20 years earlier on average, but it really is like 20 to 30 years average earlier. So that much years lost of life. And again, so these are just different ways of saying that. So the most basic form of health, measure of health, is are you alive or are you not? And people experiencing homelessness die in much higher rates for every age group. And every year, and this started with the council over 30 years ago, December 21st is observed as Homeless Persons Memorial Day, the longest night of the year, the first night of winter, where we remember around the country, cities get together, and now it's in other cities around in other countries, to remember those who have passed away while experiencing homelessness, knowing that almost every one of those is a premature and unnecessary death. So let me just skip this. There are healthcare for the homeless centers. They're special. This special term is for federally qualified health centers that have special funding to serve people experiencing homelessness. That's what my agency was. That's what there are now 300 health care for the homeless programs funded by the federal government. Each one is a federally qualified health center, and they have to meet all of the requirements of every other health center and have two additional ones. They have to do outreach in some way, and they do it in different ways. Sometimes they will build a clinic in the Skid Row area of town. They will go out and with outreach workers and bring them to their clinic. Some of them will practice street medicine by having a van that goes to different areas or goes to shelters, co-locating their services in shelters. And some of them practice what we call backpack medicine, street medicine. So let me just tell you a little bit off the council. Whenever I talk about the council, I like to start with our mission statement, and it is grounded in human rights and social justice. The National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. And I like to start with our mission statement because it tells who we are, why we exist, and how we do our work, and what is our ultimate goal. So we start off right off saying we believe that housing and healthcare are human rights, and that working to secure those rights for everyone in this country is a matter of social justice, because not everyone has those rights recognized and realized. And our goal is to build an equitable, high-quality healthcare system. We purposefully put equitable first because a quality healthcare system for some is not the healthcare system that we want, and it certainly is not the healthcare system that we need. And we do most of our work through training, research, and advocacy and part of a larger movement to end homelessness, where we bring the healthcare expertise of our community to bear and into those conversations and those advocacy. And because we believe that much of their causes of homelessness is a result of public policy, we believe we advocate, and we encourage everyone to advocate so we can change these public policies. Like I said, growing up in Brooklyn in the 70s and 80s, very poor, we did not have mass homelessness like we do now. My old neighborhood is gentrified now. But when I go there, I see people experiencing homelessness in the subways, which was not the case when I would take the subway every day to go to high school many years ago. So that's what it says on paper. But what the council really is it's a loving, supportive community. And the council is the vehicle that brings these individuals and these practitioners and those with lived experience of homelessness together so we can learn from each other. We shorten the learning curve. So we freely share what works, and most as important, what doesn't work. So I like to say, if you're working in healthcare for the homeless or medical respite, which I'll mention in a minute, either someone has already done what you're thinking of doing, what you're working on, or someone else is working on it, and there's no reason to try to figure out these big problems by yourself. So the council brings that together. And I've been very fortunate in that my mentor at my former agency in New York was the founder of my agency, started when the other organization started, and was a founder of the council. So my former agency grew, it tripled, and added all kinds of services, and it largely was from what we learned from our colleagues in the council. So I'm a big advocate for the council. If you are not a member, I'll get there, urge you to become a member as an organization, as an individual, so you can learn from our colleagues. And most importantly, you can also contribute to our learning, because we bring, like I said, we bring people together to facilitate peer learning. So our goal is to work for healthcare and housing for all. So what we do is we teach each other and learn from each other with some of what we call the healthcare for the homeless model. Now, very short, the genesis of the Healthcare for the Homeless program, which now is a federally funded program with 300 across the country, began in 1983, when homelessness was first exploding in the public awareness, and was funded by two large foundations, the Robert Wood Johnson Foundation and the Pew Memorial Trust. And they said, what can we do about the number of people experiencing homelessness? We focused on healthcare, and they created a pilot program that funded for 3 years 19 programs across the country. The program in New York City that came to the mission, and where I also did my internship and then later worked and served as executive director for 12 years, was one of those original 19. And when the federal government started to do something, they said, hey, there is this program that's really successful. And they just grandfathered the original 19 and kind of looked at what we were doing and put that into the statute, said we need to do, this is the way to do it. And so the basic elements of the Healthcare for the Homeless model that's evolved over the last 40 years is, and we didn't use those terms then, but these concepts were already there: trauma-informed outreach and engagement, where we understand that everyone experiencing homelessness has almost definitely experienced trauma in their lives, and how we approach them, how we develop our services can exacerbate that trauma and make it harder to engage them and for them to follow through if we aren't careful. We also have the term with the term consumer, is we use that term because that's what they've told us they want to use for people who have experienced homelessness, that have received care in a Healthcare for the Homeless program or a medical respite program. From the very beginning, wanted to make sure they were informing how we delivered our services, developed. Our goal is that every of the 300 Healthcare for the Homeless programs will have a consumer advisory board or some means to get this input, and have them on their board of directors as well. So the council tries to lead the way. So we have people with the lived experience of homelessness on all of our board committees, on our board. In the last 5 years, we changed our bylaws, said we have a minimum number of people experiencing homelessness on our board. We've exceeded that every year since. We've had a former board president who was someone with the lived experience of homelessness. Our incoming board president is also someone with the lived experience of homelessness. We were doing integrated primary care with behavioral health from the very beginning, before a phrase was, because that's what needed to happen. And we are very, really good at that. And then coordinating care with interdisciplinary teams, and especially working on care transitions between different parts of the healthcare system, something that we do really, really poorly as a healthcare system. And also because of the work we're doing, making sure linkages to housing is there, as well as the whole person healthcare, whole person health, all that they need. So we help facilitate that. This is just another way of saying much of the same, making sure we are focusing on, someone says, social determinants of health, so that then we can deliver enabling services, case management, referrals where they need, counseling, health education, outreach, transportation, helping to make sure that we can make sure the person is connected with all of that, interpretation. So the strength of the council, and I like to say what makes the council so powerful, is that everything we do is informed by those on the front lines, either those clinicians in Healthcare for the Homeless programs or medical respite programs, or those with the lived expertise of homelessness. And we have 3 networks, some committees, but 3 large networks. Clinicians Network, which has over 2,000 individuals, and this is anyone who delivers hand-on care to people experiencing homelessness, and that includes, in our definition, community health workers, outreach workers, as well as physicians, nurse practitioners, our consumers that has about 1,100 individuals, and respite care providers network for those who've worked in a respite care program or medical respite program or have delivered or so everything we do is informed by those in the front line. They inform and guide our work, so we know our work is timely, we know it's relevant because it's coming from those who are right there in the trenches. So we have several. I should say we are not a faith-based organization, but we have many individuals of faith, as well as many people of no faith and different faiths. But just to point out some of the members who are also members of CCFH, HF, sorry for the typo there. But Lawndale Christian Health Centers, and just say a little bit of what they do. Many of them know them, but they deliver care in shelters. During the COVID epidemic, they were instrumental, along with one of our other partners, Heartland Health Alliance in Chicago, and got all kinds of accolades for the work that they did. Really, those two organizations, both members of the council, really led Chicago's response for serving people experiencing homelessness during COVID. And everyone knows Lawndale, huge, big, really glad to have them as one of our members. Los Angeles Christian Health Centers is a faith-based organization, member here of CCHF. Their clinic is located on Skid Row in Los Angeles. I did not ever visit until I was in this role, and it just took my breath away to see how we have allowed this to happen in this country is just hard to describe. But they also do medical respite, which I will talk about. And Christ Community Health Services is in Memphis. They have a van as well as providing services in a shelter. Hope Christian Health Center is a member here as well as of the council in Las Vegas, Nevada. And their CEO is just wonderful, Steve Flores. I went to visit them last year, and they've just expanded that. Next week, I think they were going to triple the number of shelters that they were visiting, setting up clinics, doing street outreach programs. And Christ House is well known, one of the founding members of CCHF, as well as of the National Healthcare for the Homeless Council. They are the first medical respite program in the country. And now I'll talk about what medical respite is. Medical respite is a service or facility for people experiencing homelessness who no longer have a clinical reason to stay in the hospital. But if they don't have, without medical respite, they are often discharged to a shelter that can't take care of their needs, a friend's couch, or unfortunately, all too often back to the streets. So what do you think happens to their health when they're discharged from the hospital because they don't meet the clinical need to stay in the hospital any longer? What do you think happens to their health if they're discharged to one of those places? It deteriorates. Yeah, over and over. And they end up back in the emergency room in poorer health, admitted back into the hospital with higher acuity and often more complications, more conditions at great cost to their health, to the health system, and so forth. So medical respite began in 1985 by Janelle Getchis, this faith-based organization, and it's just wonderful. Sister Janelle was a founding member, not sister in Christ, not Catholic sister. She actually is her husband is a Methodist minister. Founded Christ House in 1985. They raised their family there they lived there. And what it does, it was this place, first one in the country, where the men would stay, start off with men. Often they had HIV, and they needed a place to get well as much as best as they could. And this became a model. Now, there is another program in the council network, and this just shows, like I say, the wonder of the council, that both of them claimed that they were the first in the country. So finally, I got them both together. I said, both of you, the other one is another legendary person besides Janelle Getchis, Dr. Jim O'Connell, who's still practicing in Boston. And I said, what happened? So one of them started planning first in 1985, or ready to open in 1985. The other one started a little later. And then when they found out what they were doing, they started working together, comparing notes and shortening the learning curve. So one of them started planning first, but open, and the other one open first. That's what medical respite is. Now there are over 150 medical respite programs across the country. Speaking to Lawndale Christian Health Center, they said they're getting ready to start one in rescue mission here in Chicago. This is the council. One of our strategic priorities in our strategic plan 5 years ago was to expand medical respite, and it has succeeded far beyond our expectations, and COVID turbocharged government's awareness that we need to do that. So let me just say a little bit about the council resources, and then I'll stop for questions. We have a ton of resources on our website for free. And again, it is developed by people who are doing the work or who have lived experience of homelessness, working together to make sure this is relevant and powerful. And it helped when I was the executive director and before of a health center, it just helped us grow so much and most importantly, improve our services. So we have webinars that are open. We have a number of publications. Healing Hands is from our clinicians network. We have a bi-weekly where we send out a bunch of resources. We just generate so many resources, registrations for our webinars and seminars. We do advocacy. So we have a mobilizer, which comes out once a month, as well as if there are alerts that we need people to be aware of, a number of online courses. And then we have our annual conference every year. About 1,100 people have attended the last 2 years. We've had to shut registration down early because it's sold out. And it's coming up May 12th through 15th, be in Baltimore. But also, I know that's soon, but we want to put it on your radar screen. In 2026, also will be in May, and we'll be in Orlando. Urge you to go to our webinar. I want to talk about, encourage you, if you're not a member or your organization is not a member, think about it. It's individual membership is really inexpensive for a professional. It's like $20 a year. For a student, it's $5 a year. If you're a person with a lived experience of homelessness, it's free. But that allows you to participate in our networks and in our committees. When requested, we'll send some of our mailing lists, add you to our mailing list, the ones that you want to get this information directly. It's on our website, but just the convenience, you don't have to go searching. You'll see something in real time, and it'll make you eligible to serve on our steering committees and the board of directors. But we really want people to join us organizational members like the others I focused. That really helps us to provide our services. We have some funding from the federal government, but that's about 20% of our budget, and we do a lot, and it's very generous discount for all staff members to be part of the council at no charge as individuals, but also for our members to come to our conference at a significant discount, special meetings. But the biggest thing is mutual support, so that you can be part of our community, helping each other learn from what we're doing. And so we want to shorten the learning curve for you as well. So very quick, this is give you an idea of some of our learning courses, online learning courses. We have this relatively new. These are things creating care and discharge plans for people experiencing homelessness who are hospitalized, cultural humility, effective role in building trust, some other issues you can look at our website. So again, these are written by people who are doing the work, chronic pain, co-related injuries, end-of-life care. So a number of different subjects is there for you. And because we get some federal funding and we use some of that for this is free. So I got to be honest and say, whether you join us as a member or not, there's a wealth of information on our website. And we'd love to have you join us. But more important is that you have the resources so that you can be serving your homeless neighbors better by learning from others who have done this. Healing Hands is from the Clinicians Network. The last few journals issues comes out twice a year. The current one is on family homelessness. The one before that was helping people experiencing homelessness in smoking cessation. Quite a number of them say, I want to stop smoking. And there are tips that we have learned from doing this work that we're passing on. People learning from each other, how to help people who are coming out of prison. Many people exit prison directly into homelessness. And so we end up serving them and want to help everyone do that better. And then the issue before that was on intersection of homelessness and human trafficking, how to recognize it, what to do, how can we serve people better. So I'm going to stop and just ask you to follow us on social media, National Healthcare for the Homeless Council, Google us, go to our website.